This conference will now be recorded.
Hello, everyone. I'm Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us, both professionally and innovations and things like that, but also sometimes personal issues. So today, my guest is Dr. Adam Power, the co-founder and Chief Medical Officer of Frontline Medical Technologies. Welcome to the program, Adam.
Thank you very much, Mark. It's a pleasure to be here.
Thank you. Thank you. Adam's been involved in the strategic planning of his company and is a clinical expert. He is the clinical expert on the team. And what makes you the clinical expert is that you're a vascular surgeon trained at Mayo Clinic, but you also completed a master's in bioscience enterprise at Cambridge University. And so you're both the business side, kind of, I guess, but also the technical expert on REBOA. And we're talking about REBOA today. And I had to actually write this down for myself: resuscitative endovascular balloon occlusion of the aorta.
Yes, that's right.
And let's before we jump into the clinical aspects of this, I'm fascinated. Tell me a little bit about yourself, about where you came from and your training and that sort of thing.
Yeah, thank you so much for the opportunity. And I don't generally like to talk about myself, so it'll be a little hard. But I'm a Canadian. I'm born on the east coast of Canada. Interesting thing about me is that I'm an identical twin. And my identical twin is a urologist, a urology oncologist. So it's constant. We work about 200 feet down the hallway from each other, so it's constant confusion for our patients. So grew up on the east coast of Canada. Went to university and medical school out there. Did after graduating from Dalhousie University Medical School, I went and did my general surgery at McMaster University in Hamilton. That's in Ontario, near Toronto. Partway through my residency, some of my research involved very early stage prototype development of medical devices. As a resident, I kind of didn't want to get involved in chart reviews. I thought I've always been an inventor at heart, and why don't I just come up with something? And so my twin brother and I came up with something, and we had it machined, shopped in one of the machine shops. It was a metal instrument, and we piloted in some pigs, and we presented it and patented it. There's a lot of P's in there, lots of alliteration.
What exactly was the instrument?
It was, well, I'm a little embarrassed to talk about it because it was with a natural orifice surgery, which probably 15, 20 years ago, laparoscopic surgery, there was some talk about going through, endoscopically or, through other orifices in the body, making a hole, going out and doing something. It was incisionless surgery. So no external, but it was all on like cutting the stomach open, removing the gallbladder, pulling it through the stomach, suturing up the stomach. Anyway, it never really took off, but it was a device. It was a device for that. I certainly didn't come up with that, but there was something about it that, anyway, we got to the end of that, and as a typical doctor, I had absolutely no idea how to talk to industry. I figured that they would just come and scoop it up, and my brother and I would be millionaires, and we'd go off into the sunset, but that didn't happen.
I know a lot of doctors. I've talked to a lot of and the fact that you're an inventor is really not unusual. I've seen a lot of physicians who have, they look at what we do and think, there's a better way to do this, or there's the less invasive or more effective, or there's a lot of different things that physicians see. There's a lot of advancement that occurs that way, but that's that step that oftentimes people don't know how to do, and they end up, it doesn't make it to market, or somebody else gets the credit for it, or they don't get the compensation that they would otherwise have because they lack the business acumen to do so. So it sounds like you turned around and got educated to do that.
I did. That's a perfect segue into how I got into Cambridge. I went over to the UK and did this sort of mini MBA introductory course to biotechnology, intellectual property, medical devices, and it was really just a great introduction. Met some wonderful people, made some great contacts, and I learned the lingo to use
Yep.
and how I could build a business case for any device that I would ever come up with. So um, finished off my general surgery training in Hamilton, went to Mayo Clinic, was way too busy there to be inventing anything. So when I got to where I am right now at Western University in London, Ontario, which is actually about a couple hours from Detroit, that's where we are located. But that's where I really focused a lot of my energies, my academic research into prototypes and medical device development. And I filed, upwards of 15 or so provisional patents, US provisional patents on various things. And I would present them to medical device companies and have the lingo. And I sold a couple of those patents. A lot of them just went to the wayside, went by the wayside. I did some consulting for those companies where I sold the patents to. But I realized that if I'm going to see any of these inventions in my lifetime, because big companies are wonderful, but they're just slow moving ships. I
Yep.
thought I better do this on my own. And so one of the, I'm back probably about 5 years ago, and REBOA was just sort of hitting its mark, and there were some great studies coming out about it. I thought, I can come up with something better than that, and I have to bring in my partner, Asha Parekh, who I certainly could not have done any of this without, because I still am a full-time practicing vascular surgeon. She is a PhD biomedical engineer, brilliant mind, also an inventor. We sort of came together here at Western University. We were, the stars aligned, and we started working on this project together. She quit all of her, other things that she could have done amazing things elsewhere, but she decided to head this up and work full time for the company. And initially, I think we started with $70,000 as a grant from our local government here. And I said, okay, 30 of that can go to your salary for 6 months, and the rest we'll put into development, and let's just see if we can keep it going. And we haven't looked back since
That's
then.
great. That's
Um,
great.
yeah.
Well, the company actually, Frontline, I mean, what would you, I'm just going to throw it out there. You feel free to say no, but what would you say that the company's worth now? I mean, you started with a $70,000 grant. How far have you come? Have you gone through series, what the various series of investors and that sort of angel investors and Series A and all that?
We have pitched. I personally have pitched like over 100 times. I wouldn't say 500, but and I failed at most of them. I'll tell you that.
You only need one or two.
That's right. So we've been very fortunate that we have had mostly private investment. We've had a few strategic smaller investments, but right, we're still a private company, and actually, potentially going to be raising money further in the next. So our valuation is smoke and mirrors, to be quite honest.
Well, I wasn't trying to put you on the spot, but I'm thinking a number of physicians actually do listen to this podcast with the idea of finding young companies like yourself that have potential, that they know have clinical application. They have enough personal knowledge to know they have clinical application, and that they might, get on board as investors as well as customers. And so sometimes I like to kind of assess where you are in your development, because there are listeners who might jump on the boat with you. So anyway, that's
Yes, thank you very much. I really right now just pre-commercialization, because we're getting close to that. We have just closed a large investment. So we're not currently looking for investment, but obviously as your company grows and changes, those will be open down the line. So we haven't quite gotten to needing Series A funding just yet. So that's kind of where we're at. Yeah.
Gotcha. Well, let's talk about the clinical applications of REBOA to start with. Just give me an overview. I think most of us are vaguely familiar, if we don't use it specifically, vaguely familiar with REBOA, but kind of start from, assume I'm a community physician, emergency physician, and where would REBOA fit into what I see?
Yeah. So, like you said, REBOA is resuscitative endovascular balloon occlusion of the aorta. And what that essentially means in this day and age is that you get access to one of the femoral arteries. Okay. Usually under ultrasound guidance, you get, an initial sheath in place. And then most of the time it's done blindly, where you place a catheter through the actual access point up into the aorta and inflate the balloon.
How large? How many French catheter are you putting in? How big?
So that's the whole issue, and I'm glad you asked that right away, because we saw that as one of the main issues for using these catheters and doing. So most devices and that are currently available right now are 7 French. Okay. And just to give you an idea about 7 French from a practical perspective, is most cardiologists and vascular surgeons and interventional radiologists, we typically use 5 and 6 French sheaths. Yeah. And if you pull those out, you can usually hold pressure, and it's, percutaneous access with manual compression is fine. When you get up to 7 French, that's a long time holding manual pressure. You have to potentially use closure devices, and the complexity gets higher and higher. Right. We wanted to really design something that was like an art line. So we went all the way down to 4 French, which is a miracle in my opinion. I didn't think we could get there, but we did, and we were able to get to 4 French, which is literally just a tiny bit larger than a typical femoral art line that you would use. Doesn't fit through the femoral art line, but it fits through a 4 French sheath, which means, a lot of the times we're thinking people are going to put a 4 French sheath in as the art line, and then you don't have to upsize the sheath or do anything else. You just have access to put in the REBOA device right away. I think an important point from the original devices, which were 12 French, 14 French, these things were hoses, and you needed to cut down the artery and actually suture the artery closed, is that these were all over the wire. So you put a wire up blindly, and then you track a device. And what that means, practically speaking, is on the outside of the patient, you need a very long wire and a long device. In the trauma bay, these wires flopping everywhere. There's no sterility. So it's a big advancement to not have to track these things over a wire. They have atraumatic tips, and ours has an atraumatic tip. There's no wire, it's access. And then through there, you go up with the device that's atraumatic, and it's got a J-tip on it so it doesn't go into branches and goes up to the appropriate spot in the aorta.
Now, is this something you have to do in the cath lab, or is this something that you can do actually in the emergency department?
Yeah, it's actually been done roadside over in London, UK. It's been done pre-hospital in the military. People have been putting these things in austere conditions. Wow.
I was in a shock trauma platoon in Iraq, so I know what I was going to ask you about that, about whether this had applications for the military, particularly like we were at, in forward deployed tent settings and that sort of thing. And you're saying yes.
Oh, 100%. The original REBOA idea was from the Korean War, many years ago, but it had a resurgence because of the U.S. military. There were some physicians, Todd Rasmussen and Eliason as well, Dr. Eliason. They with their military experience, recognized that with these junctional injuries, so you had plates and armor for your chest and back, but you had to be able to run and move and shoot. So the junctional areas were where shrapnel and debris was coming up, and so a junctional injury in the pelvis was an absolute catastrophe, and many soldiers were dying. So if you can do this even right there at the scene, you put the REBOA balloon in and you tamponade things so that you can bridge to a definitive far forward environment where you could actually get surgical control. So that's the idea, was pre-hospital, and it hasn't quite translated yet into pre-hospital paramedics in many places. There's a few places around the world, but that's where, you know, we've in the thinking about REBOA, I've always seen the greatest benefit. If you're in the actual emergency department and you're at one of these high level 1 trauma centers, of course you can just, their OR is just down the hallway. So why are you taking all this time to do REBOA and everything else? And that's why we simplified it and tried to make it so easy that it wouldn't be. But anyway, but pre-hospital, if the patient never even makes it to the hospital, then you can't save them. So that was ultimately, and that's where I see it going in the next few years. So, and I should just mention resuscitative thoracotomy, because that's, you know, like resuscitative thoracotomy is done when you don't have access to REBOA. So if you have a patient that's crashing in front of you, they're unresponsive to resuscitation, you can open their chest, put a clamp on their aorta, and REBOA does the same thing. What it does is it essentially closes off the circuit. Like, so instead of the circuit being the whole body, the circuit short circuits and it's the brain and the heart. So if you've lost 2 liters of blood, what's in there is just going to circulate to the brain and heart, keep that alive. You get resuscitation, you let the balloon down, or you get definitive control. So resuscitative thoracotomy, there was some argument initially about, well, I can do resuscitative thoracotomy faster than you can do REBOA. But, you know, that was with people that, you know, weren't skilled in sort of ultrasound and endovascular. So like a lot of those physicians did not adopt sort of the newer technologies and things like that. And so the newer generation of surgeons all have ultrasound skills and access skills and want to be doing things minimally invasive rather than doing a massive thoracotomy. So I should say, like with our device, the Cobra OS, which is actually an acronym itself, we could.
Right. I wanted to ask you about that. The Cobra OS. Explain. It's the control of bleeding, resuscitation, arterial occlusion system.
Yes, it's for trademark and logo purposes, we added the OS as well. So initially we call it the Cobra, but Cobra OS is certainly its full name that we go by. But it is an acronym, and you know, it's the Cobra snake is, you know, it's not the biggest snake, it's a smaller snake. It's pretty fast, so we kind of love the idea, and you know, I have lots of Cobras around. I have, like, everybody buys me like little toy Cobras. Yeah, so the Cobra OS, we designed it to be very convenient. So nobody knows where all these wires and access kits and everything. So we said, okay, let's include this really nice 4 French access kit in the package, so you can get access with everything you have there. So, and it can just be an art line if you want it to be. And then we have the device itself, which is 4 French. You mentioned doesn't have to be done in the cath lab. It actually doesn't, because you can blindly place it up into the aorta, because it just stays in the right space. And then the positioning is, they've done the studies. You know, we as the group doing REBOA research know that at 28 centimeters and 48 centimeters are the 2 zones for 95% plus of people. So if you want to go to the descending thoracic aorta, it's 48 centimeters, which means because zone 1 for REBOA, which is closer to the heart, is distal to the left subclavian above the celiac artery. That's a pretty long zone in people. So for tall people, it'll be a bit lower. For short people, it'll be a bit higher. But that 48 centimeter mark is a good place for blind placement for most people. It's a little less reliable for zone 3, which is at the aortic bifurcation below the renal arteries. And there's different applications for why you would use one versus the other. But so we have those gradations on the device as well. So that what happens is access, device up to mark, inflate. Now, when you inflate as well, there are some issues, because inflating a balloon in the aorta is like, oh my gosh, like that's a big step for a lot of people, because they worry about obviously rupturing the aorta because they don't know, you know. But so that's why we use compliant balloons. And that gets into all the material science behind this. But what really is important about that is they're not like angioplasty balloons for the heart, where you crack open a lesion. These are really soft sort of balloons that sort of mold. They're aortic molding balloons for endografts. So they mold the aorta, so they don't rupture the aorta. You can actually hit and occlude and inject more fluid, and it doesn't actually damage the aorta. We added a special safety feature to our balloon, which is unique to our balloon. It's called the safety shoulder reservoir. Again, I'm not sure about any of these names, but it was trying to explain that once you hit profile, instead of continuing to grow radially and rupture the aorta, it actually grows in length. So we can put in a ton of fluid without rupturing the aorta.
You know what it reminds me of? If you think of the clowns who blow up the balloons, and they blow really hard until they get a little tiny bubble at the end of the balloon, and then the longer they blow, all it does is just get longer and longer and longer. That's really what you're talking about.
That's exactly right. Like the party balloon technique, exactly. That was sort of the idea. And so it was more to actually grow in length. We didn't want it to grow too long, and so we have some limits on that. But you know, arguably speaking, we wanted to be really safe in a blind insertion, placement, inflation. Where REBOA gets its bad name is not from any of the stuff that we necessarily just talked about, maybe from access, especially with the larger devices, when you're pulling them out and you get access complications, or even having a large device in, even 7 French in a hypotensive patient, you're not getting much flow to that leg, but 4 French, arguably, you're getting more flow to the leg. So, but it's that blockage. And now, how long do you keep the balloon up for?
Exactly. That was my next question. I was going to say, how long will this last?
Yeah, we don't know that answer, but I can tell you the smart people who have written the guidelines on this say that 30 minutes is probably safe for zone 1 occlusion, which is distal left subclavian above the celiac artery. Zone 3 is probably between 30 and 60 minutes, but we don't really know that data yet. And so this is where some of the difficulty, there's a lot of positives research. I should say there's no randomized controlled trials done on this yet. There's one going on in the UK right now. But, you know, people talk about this not having the evidence. And I mean, that is true. I will say, though, that as a vascular surgeon fixing ruptured aneurysms and having to clamp the aorta, like, we've never randomized clamping the aorta.
Right.
It's a tool. Like, you can't just apply it like a drug.
Yeah.
And so if you're going to say, and that's the problem with randomized controlled trials with any sort of surgical procedure, because there's too many variables. And arguably, if you're going to do it in a trauma patient, it better be the same splenectomy patient done 100 times. Like, it doesn't make any sense. But if you're going to say that it's like a drug and study it like a drug for randomized controlled trial, the pill is the device and the dose is the length of time. So of course, if you overdose somebody with any drug, like Tylenol is safe in low dosages, but if you give too much Tylenol, people will die from it. Same with REBOA. There is a limit to it. So, you know, people have said, oh, there's kidney failure and there's potential amputation. And yeah, if you're doing it on the wrong patient for too long. But if, you know, I think that's where we're headed is better patient selection and knowing that you can't just turn it on and leave it on for, you know, X amount of time. You have to constantly be thinking about deflating that balloon. And then there's even discussion about partial REBOA as well.
Right. In fact, when I've been involved in discussions on ECMO, and and this is a very similar discussion that goes on with ECMO. And one of the things that's developing with ECMO is the idea of alternative vascularization of the distal portions, and that may be something that the balloon is any port in a storm, and then the second phase may be some kind of secondary vascular supply to the compromised area. I don't know. It's a whole nother discussion, but still, I think that both of these technologies, and I'm really excited about both of them, but both of these technologies are relatively early. I think, even though you say it started in Korea, the idea has been now become more efficient, and the idea of being put in the hands of people earlier in the chain, that a lot of lives could be impacted by it. Let's go on. Let's talk about the clinical impacts. You sent me some talking points here, which I really like. We talked a little bit about the refractory hypotension and trauma and the alternative to resuscitative thoracotomy. Let's talk about postpartum hemorrhage. When I saw your talking point on this, I thought that's fascinating, because I've actually seen some cases like that in the emergency department where somebody inadvertently, blindly did a pelvic exam on a previa, and they ended up with a garden hose bleed, and they were in real big trouble. And so I'd like to hear what you have to say about that.
Yeah, it's it's a major problem worldwide. Even in North America, it's still a problem with all our great care and great prenatal care, and it still happens. There are these, and I don't profess to be an expert in the actual obstetrics of this, but I am an expert in bleeding control. And I have been involved in some of these cases. There's something called accreta, or morbidly adherent placentas, like you mentioned. Right. So if there is significant bleeding and you can't get control of it through your various methods, then hysterectomy or patient death is a potential. If we think about those accreta cases, we can branch out to the postpartum hemorrhage, but if we think about the accreta cases, there are some groups in the world that actually place balloons prophylactically before they get into the bleeding. They know that this is going to be a bleeding scenario, and they put these balloons in. So they put the balloons in various different places, not REBOA balloons. This was before sort of REBOA was even known about. They put them in the internal iliac arteries, bilateral. The interventional radiologist would do that and inflate them. Didn't work that great. They put them in the common iliac arteries, which started to work a little bit better. But interestingly, placing the REBOA, the REBOA devices now designed for the aorta into the zone 3 below the renal arteries is having a better effect subjectively. Again, I have to preface this with not a ton of data on this, but it's because the ovarian arteries actually come off below the renal arteries, and they supply a lot of blood flow to the placenta. And so if you do Zone 3 REBOA, it allows you to catch up sometimes when you're doing these cases, and if there's tons of bleeding, instead of going straight for the hysterectomy, then you can often put the balloon up, gain some control, deflate the balloon, those types of scenarios. And having a low profile system in a patient like that is super important, because These are often young patients, vasospastic blood vessels, so they're just tiny blood vessels. Plus, you've got the hypercoagulability of pregnancy. You know, like it's always a double-edged sword. Helping with blood control, what are the complications? How do we deal with them? How do we minimize them? So, but it's a fascinating thing, and even thinking about, I mean, third world countries where they don't have a lot of the medications that are involved, and
Right.
you know, like they don't have the capabilities. I mean, it's a bit of a far-fetched idea, but I can imagine in one day, you know, these types of devices helping in the third world and helping save patients where postpartum hemorrhage is a major issue, and that's something that we as a company really hold dear as well.
That's great. That's fantastic. Now, your third case scenario had to do with non-traumatic cardiac arrest. Non-traumatic cardiac arrest. Tell me, let's talk about that.
Okay, this is my favorite. Actually, I feel like REBOA is great in trauma scenarios and various in pre-hospital and military, obviously. But this is the thing that really excites me and excited me actually when I first started this company and the device. So the idea is that you have a patient that has a cardiac arrest for any number of reasons, and you start CPR. If CPR is generally ineffective when you're pumping blood to the whole body. So if you do a REBOA device up in sort of zone 1, you close off that circuit and all of a sudden your CPR becomes theoretically much more effective. And you mentioned about eCPR and pre-hospital ECMO. These are potentially patients, if you can get them back with REBOA and they get return of circulation, these are the patients that might be the ones that are self-selected for the ECMO cases.
Yeah.
So, but it's theoretical. There's lots of pig studies. That's awesome. But where are we at with human data? Well, oh my gosh, they did a trial over in Norway. This is an amazing study. If you haven't read it, you should check it out. They did 10 patient feasibility study, and they showed up wherever, out of hospital, cardiac arrest, and put these REBOA balloons in. It was a highly skilled and trained team. So it's not obviously for everyone, and out of the 10 patients, they got a 60% ROSC rate, which, you know, normally it's 10% at best. That's amazing.
Yes, it is. Yes, it actually is. We've been discussing this at Emergency Physicians Monthly for the last several months. I've been really excited about the various technologies, resuscitative technologies, because, you know, emergency medicine was kind of built on the idea that CPR and early intervention like that was going to make a big difference, and it really didn't work out. I mean, honestly, to be fair, now that the specialty is matured, I think we can be honest about it and say that all this chest compression so far has not done what we thought it was going to do. And now that we have some of the advancements like REBOA and ECMO, we're starting to see some huge strides forward in resuscitation, and it's pretty exciting. It's almost like a second phase for emergency medicine to have these technologies available to us, or soon to be available to us, which we could really make an impact on resuscitation. So yeah, you're absolutely right. I didn't want to cut you off, but this is a very exciting area for emergency physicians, is the idea of being able to salvage a lot of these people that have just not made it before.
I totally agree, and this feasibility study actually paved the way for the randomized control trial that they have it up and running. I don't know where the recruitment is, but I think it's 100 patients in each group, and I mean, the world is awaiting these results, because this is amazing. There are some in-hospital cardiac arrest trials. I might get this wrong. I don't know a lot of these people, but in New Haven in Connecticut, I believe they're doing a trial for in-hospital. So in emergency departments, they show up and arrest. They're witnessed arrest and appropriate criteria, they're doing it. You know, there's been this argument that, okay, well, what about neurological outcomes? And even if we get patients back, it's potentially increasing organ donation. So there are some side benefits to even
Yeah.
just the growing pains of this thing. So I'm really excited about it. And and that's where it gets back to simplicity. Like the ACLS algorithms are all about simplicity, and so you can't overcomplicate, these things. And that's where, if REBOA is going to be done, again, I'm not saying to do REBOA on everyone, but if you're going to do it, it's like trying to do it as simply as possible, especially if you're not doing it every week or every month. It has to be intuitive. It has to be very
Yeah.
safe.
Yeah. Any emergency physician should and has put in numerous femoral art lines. I mean, we're all very familiar. We can do them blind. You obviously, I'm an old guy, so I train doing them blind. But certainly the younger physicians all have skilled and access to ultrasound, can see what they're doing, and can put in the big femoral art lines. 5 French art lines are, any trained emergency physician should be able to get in an art line of that size or larger for that matter. So when you said 4, I was flabbergasted. And so 5, 6, 7, you can do, but if 5 we do all the time. And so a 4 French art line, a 4 French REBOA line is something that can be done very quickly and very reliably. And so that's pretty exciting. That's amazing.
Yeah, my colleagues actually didn't believe me when I said 4 French.
I didn't.
Yeah, and they said, "Are you sure?" And people actually mention 5 French more often than they say 4 French, because it just is not a 4 French. People have never really talked about. We're getting into like radial artery intervention for coronary procedures are 4 French.
Right.
Like these things are tiny, which means in the radial artery, if it can fit in there, it can fit in anywhere. And so,
Yeah, exactly. Yeah, I mean, that's what we the standard trauma sleeve going in is a 5 French, and we do those all the time. You mentioned in here another case application was a GI bleed or an organ transplantation. Let's talk about that a bit.
yeah, so there are some other non-traumatic reasons, especially like GI bleed is a good example, because there's a bleed and you want to get endoscopic control, but there is a period of time before you can get that organized. So patients are often bleeding, waiting for the endoscopist to do the endoscopy and inject or clip or do whatever for the bleeder. It's been seen anyway in some of the registry data for non-trauma cases that it's been seen as a good bridge.
Yeah.
And I personally had a case where we had a young patient with splenic artery aneurysm rupture, unstable, normal aorta, perfect for a REBOA or these types of things, and we didn't know why she was bleeding. And it was either going to be resuscitative thoracotomy or something, but REBOA, can be very useful in those circumstances. The organ perfusion, organ donation is interesting, and I even bring that up. It hasn't really been talked about very much. We did our first in human study in organ donors, and I have to say a big thank you to the families and to the donors that donated and consented to this process. So we did a feasibility trial on 7 patients to see if this was possible to do our device and how fast it was. We averaged about 70 seconds to actually get from the skin poke to aortic occlusion. So it's very fast. You can get these devices. But why were we even able to study that sort of population? It's because REBOA is actually being talked about, not specifically the words REBOA, but aortic occlusion in something called normothermic regional perfusion. So if you have 2 types of organ donors, generally speaking. One is donation after cardiac death, and the other one's after brain death. The brain death is much more stable patient.
Sure.
They come into the OR, everything's all, and that's what we did our feasibility trial in. but there's a much greater potential population of donors that are after cardiac death. But their organs aren't as good or aren't as preserved, is because you have to go through the act of them dying, rushing them to the OR, crashing in, harvesting organs as fast as possible, and they just don't do as well because it's. So there are pockets around the world that have started placing REBOA for reverse reasons. And so why is that? Is because what happens is you actually do ECMO of the abdominal organs and the viscera, and the actual balloon stops reanimation and stops blood flow up into the brain and the heart, so you can let the patient die above the balloon while you're giving perfusion to the abdominal organs, and that has been shown to increase the quality of the organ donation. It's very ethically challenging, and with respect for many patients' family, you don't want to be too invasive. So doing cut downs and placing balloons in and including the aorta is something that's been seen as very invasive to someone at the end of their life. And so these lower profile balloons and these REBOA balloons have been talked about to be used as something more of like an art line and an occlusion, and it's less intrusive to accomplish the same thing. Again, never been done, really just sort of lots of theory around it, but it's an interesting thing to think about in the future.
That's great. That's fantastic. One thing you didn't have in here, and maybe correct my ignorance if I'm off base on this, but what about the use of REBOA in the situation of aortic dissection? And I've given you time to get in on the crash dissection or ruptured aortic aneurysm.
Yeah, great question. And so what I would say is that, so I have to, if I'm wearing my company hat, it is off-label. It's it's not to be used in aortic dissection, but aortic dissection or potentially aortic rupture, because the aorta is not normal and it's hard to get these balloons up blindly through these tortuous segments in the aorta. All that being said, I will tell you that I've had some Canadian colleagues that are really excited for this, because we can potentially be placing these lower profile balloons in the emergency department to and we'll have to use fluoroscopy potentially to do that, because it's not exactly blind, to get these devices up and get aortic occlusion, supraceliac control before even having the patient go to sleep. So we can do it in the OR while everyone's resuscitated, put the balloon up. We do that for ruptured aneurysms now with the large profile devices. Some of the things about the lower profile devices, you can actually come from upper extremity access as well, which is really exciting, is you can come in from the arm, like, arguably speaking, come in from the brachial, high axillary, and the balloon actually sits just above the celiac artery, and you can have somebody sort of occluding and not occluding above all the repair and everything that's going on for an infrarenal abdominal aortic aneurysm rupture. Yeah, I think vascular surgeons and interventional radiologists, cardiologists are going to find some fancy things to do with this low profile balloon. I mean, we even talk about and this is a little tangential, but just to give you an idea of where people are going with this, is that we use these balloons as potential backstops. So if we're trying to get into a very, for our advanced endovascular aneurysm repairs, if we're trying to get into a downgoing vessel, you can inflate a balloon and use it like a backstop, like a basketball, and to bounce off it and go in. When you're using a massive high profile balloon, it doesn't work, but these lower profile balloons people are going to be able to get creative with it. So.
Fascinating. Absolutely fascinating. From a physician who has practiced most of my career in not academic settings, I realize that the vast majority of the people who listen to this podcast are probably in that boat. And they may not have, 30-minute or 15-minute access, maybe 30 minutes, maybe, but access to some of these super specialists or these procedures. And this kind of thing would have an impact on their practice. If I could keep somebody alive for 30 minutes, if I could slip something in and put them into a helo, and get them from, Kansas, some outlying hospital in Kansas. Anybody who can put in an art line could save somebody. I think there'd be a lot of interest. And I guess I want to end the podcast by asking you, speak to me if I'm out in Augusta, Kansas, and I want to hear more about the actual use of this and how I might be able to use it in my facility. Who do I talk to? Where do I get the research? What's the process?
Yes, thank you for that. And I will tell you, I'm very hands-on. I love this stuff, as you can tell. I'm very passionate about it. And I'm also passionate about getting, REBOA safely. And so it would be me talking to anybody that would want to talk to you about it. Of course, there's various people in my company that I might bring in for questions that I don't know. My email is adam@frontlinemedtech.com. You can go to our website, www.frontlinemedtech.com. There's lots of information on there, but I would just encourage people to reach out. This is a team sport, and we need to all work together and that's just not us as physicians, emergency docs, vascular surgeons. It's also industry as well. I mean, I'm on the other side now, and my pure focus is the patient still. I need to make a feasible business, but we all need to work together to make sure that patients are benefiting and not suffering from our new technologies.
Yeah, say that email one more time slowly.
Yes, it's adam@frontlinemedtech.com.
Adam, ADAM at frontlinemedtech.com.
That is correct. Yeah.
Great, that's fantastic. I think you'll get some emails from this. I certainly hope so. This has been fascinating, Adam. I've enjoyed talking to you. I especially love the fact that Emergency Physicians Monthly has had the opportunity to talk to some folks on the very cusp of new technologies or advancements or refinements of technologies that we've maybe used in the past, but they didn't make it into the hands of the people who could utilize it the most. And I think that, as I mentioned, it's the folks who are maybe just outside that circle of high intensity tertiary care that would be able to really use a technology like this. So I would urge you, if you are an emergency physician that is practicing in that kind of community setting, and you've seen patients that have not been able to make it because they just couldn't get the time, I would encourage you to get in touch with Adam and have further discussions and see if this kind of technology applies to your facility. So Adam, thank you for joining EP Talk. It's been incredibly informative. I enjoy it, and I wish you well with Frontline MedTech. And we'll have to get together again when you're starting to look for your investors, because I think there might be some guys out there interested in getting involved.
Well, Mark, it's been a pleasure. You're such a nice guy, and thank you for doing this for all the emergency docs out there. And yeah, it's a great service you're providing.
Well, thank you, Adam. Take care, everybody, and thank you for joining us today at EP Talk. I hope you'll join us again, and thank you for the afternoon. Bye now. Okay, that is